Hi, and welcome back to MedShoots. In today's shoot, we're going to discuss the complications of an acute myocardial infarction, or AMI for short. As part of this, we'll discuss the events that lead up to the infarct, and then we'll discuss all the things that can happen at the different time points over the course of an infarct and its healing. One of the good things to start this shoot off with is to mention that the complications of AMI at the moment are actually pretty rare. We've had a massive drop in the long-term complications of AMI because we now have methods to ensure rapid reperfusion in the case of heart attacks. So now what used to happen is when someone had a heart attack and they got taken to hospital, often there wasn't a lot that could be done. They just had to wait it out, and often you would hear code blues called to the cardiology ward for patients about a week out from a heart attack who suddenly had a ventricular wall rupture, a fatal arrhythmia, or they've suddenly gone into acute heart failure. Because we now have these methods to rapidly reperfuse the infarcted tissue or the ischemic tissue, we see much less of these now. People can still die from heart attacks, and often when people do die, it happens in the immediate kind of acute stage within 30 minutes of the infarct happening. However, these long-term complications we see much less often now, which is a really good sign. And that's one of the reasons now that AMIs have much less lethality than they used to. It used to be that having a heart attack was a death sentence, and that's now no longer the case. And we have a lot of people now that live with chronic kind of cardiomyopathies and chronic ischemia who don't necessarily have all these nasty side effects of having an acute myocardial infarct. So to start off with, how does an infarct occur first of all? It's to do with these atherosclerotic plaques in the coronary arteries. So you can get atherosclerotic plaques in any of the arteries in the body. Some common areas are the carotids, the coronary arteries, also in the aorta and around the bifurcation of the aorta, in your iliac vessels and the femoral vessels, that kind of thing. Typically, you get plaques happening in bifurcations, so the bifurcations of the carotids, the bifurcations of the aorta into the iliac vessels. They're the kind of areas where it happens because you get this turbulent blood flow. The coronary arteries, though, are also quite predisposed to developing atherosclerotic plaques. These plaques can become unstable, and then that can lead to an acute plaque event. Depending on where you are in the body, you can develop atheroemboli, which is where bits of the clot that form on the ruptured plaque or bits of the plaque itself get thrown off into the blood vessels back, and they kind of get carried somewhere else in the body. So atherosclerotic plaques in the carotids typically produce these atheroemboli, which get flicked off and into the brain and can cause a stroke. The other option is you can get a thromboembolus, which is where you get a big clot forming on the ruptured plaque. And that's typically what happens in the coronary vessels. So in your coronary vessels, you get these acute plaque ruptures and thrombus forming. And the thrombus very rapidly occludes the coronary artery. And that means that you no longer have blood perfusing that area of the heart. And that leads to myocardial ischemia. If this resolves within 20 minutes, then we class this as unstable angina. So before 20 minutes, all the ischemia and the damage that happens is reversible. So the cells can heal from it, and they can adapt, and they can develop mechanisms to try and increase perfusion. However, once you get past the 20 to 30 minute mark, you start to switch into irreversible injury. And when the irreversible injury occurs, we call that a myocardial infarction. The irreversible injury results in cell necrosis. And what does that kind of look like? So the first thing that we see within 30 minutes of the infarct occurring is disruption of the sarcolemma. The sarcolemma is the cell membrane which surrounds cardiomyocytes. When the sarcolemma is disrupted, everything that's normally within the cell starts to leak out. So in particular, the ones that are important are these cardiac enzymes, so cardiac troponin and cardiac CK. The reason these are important is that we can test people's blood for this to determine whether cell necrosis has taken place. If it is a case of unstable angina, you shouldn't get disruption of the sarcolemma and leak of these enzymes. This should really only happen when there is cardiac death, when there is actual necrosis happening of the cardiomyocytes. This typically takes 3 to 4 hours to elevate. So when patients come into the hospital with chest pain, usually what we'll do is we'll get a troponin sent off straight away to give us a baseline. And then we'll take a troponin about 4 hours later in order to see what it's doing. If the cardiac troponin is elevated but stable, it's unlikely that they've had a heart attack. They might have another condition that's leaning to troponin leak or poor clearance. However, if it comes back and there's been a significant rise in the troponin, it implies that you've actually caused an infarct and you now are undergoing necrosis in the cardiomyocytes. The other side effect of the disruption of the sarcolemma is that you get the current that allows the heart to beat. That starts to leak out. And that's because the current is actually to do with this potential difference across the sarcolemma, across the cell membrane, due to the concentration differences between potassium, sodium, and calcium across the cell membrane. When you lose your sarcolemma, suddenly all those ions can start to diffuse wherever they want to, and that means that you lose the current. And the current means that losing that current, leaking that current out, changes the ECG pattern. With heart attacks, infarcts, we typically see two patterns, and these are the ones that we often talk about. The first is a STEMI. And a STEMI refers to an ST elevated myocardial infarct. ST is a region of the ECG. And if you see a STEMI, that is specific for an infarct. So really you only get ST elevation if there's an infarct. In particular, if it's following certain coronary perfusion areas on the ECG. So when you've got certain groups of leads that have ST elevation, that's an indication that an infarct has occurred. And I might do another shoot at a later point on reading ECG so that these terms will make a bit more sense. The other type is an NSTEMI, or a non-ST elevation myocardial infarct. This indicates ischemia, but it's not confirmation of an infarct, so it's not specific for an infarct. Because of that, if someone is having an NSTEMI, we actually don't know for certain if they have an infarct or not until we get their troponins back. The main kind of complication that you can get at this early stage is heart failure and arrhythmias. The risk of these is greatest at this point, but it kind of decreases the further out you go. And people who are years out from a heart attack are still at risk of developing heart failure and an arrhythmia. However, the longer you go without a complication, the less likely you are to develop that complication in the future. So what happens here? The reason you can rapidly develop heart failure is because when your cardiomyocytes become ischemic, while they might not be dead, or if they are dying, they actually become non-functional for the period in which they're ischemic. So they can't beat, they can't contract. And because they can't contract, you lose your contractility in the heart, and you therefore then drop your cardiac output. When you drop your cardiac output, that is specifically if that's happening in the left ventricle, what can then happen is that you start to get a backup of all the blood because there's now instead of emptying your ventricle with each contraction, at the end of systole, there's an increased end diastolic volume. There's still lots of blood sitting in the ventricle at the end of systole, and then that increases the pressure, kind of backs up the system, and that can cause, so the heart failure is that you lose your cardiac output at the same time that you're backing up all this blood, and the backed up blood can cause acute pulmonary edema, or it can cause acute heart failure, and that people get fluid overload, peripheral edema, that kind of thing. The more serious one is the acute pulmonary edema, because that means that people start to go into respiratory failure as well as having this heart attack. With the arrhythmias, that can occur when ischemia is happening to any of your sinoatrial or interventricular nodes, or anywhere along the His-Purkinje system. If you make these areas ischemic, you get errors with the conduction system of the heart, and because of that, you start to get aberrant beats. Certain parts of the heart might not link up perfectly with the rest of the conducting system. Certain areas might miss out, and that means the heart starts beating out of rhythm. And that leads to the arrhythmia. And the ones in particular we're worried about are ventricular fibrillation and ventricular tachycardia. These are the ones that can cause cardiac arrest. You can also get asystole, and you can get a PEA arrest. But the big ones that we really worry about are VF and VT. And that's when you hear of people who have heart attacks and then they die almost immediately. So they kind of are walking along and suddenly clutch their chest and fall over dead. Usually, and if the cause of death is a heart attack, it's usually a fatal arrhythmia that's occurred, and that's what's killed them instantly. So that's all happening within, the first couple of hours following an infarct. If we then go 1 to 3 days post-infarct, that's where we're seeing our acute inflammatory state kind of going on. And you can see this at a histological level. So after 24 hours, your troponin peaks, which means that your cells all the cells that are going to die pretty much have died by this stage. And when you look at the histology, there's lots of neutrophils within infiltrating the area because it's this process of inflammation going on. And again, the main risk at this point is heart failure and arrhythmia. After about 3 days, you start to switch from this acute inflammatory period into this period of early granulation. And that's marked by your neutrophils starting to move out of the tissue again, and you then start to get an influx of monocytes which differentiate into macrophages. There's two kind of processes that occur during early granulation. The first is that with this monocyte influx and the macrophages in the tissue, what they're there for is they're trying to eat up all the dead tissue, all the necrotic tissue, all the necrotic debris. And so as part of that, they're kind of picking everything up, but they can also be spitting out some cytokines as they transition from an M1 phenotype to an M2 phenotype. So M1 macrophages are the inflammatory ones, M2 macrophages are the healing ones. At the start of granulation, you've mainly got these M1 macrophages around, and they're eating up the necrotic cells, but they're also releasing cytokines. And that cytokine release can result in inflammation of the pericardium, leading to a pericarditis. That causes a sharp pleuritic pain, so pleuritic meaning a sharp stabbing pain when people breathe in. And that pain is typically worse when the patient lies supine. The other thing that's happening at this time of early granulation is you're getting fibroblasts migrating into the area and promoting angiogenesis. So they're promoting the formation of new blood vessels. They start laying down new collagen. And collagen's a bit like cement. When you first make it, it's not actually very strong, and you need to give it time to cure and mature for a couple of days and up to a few weeks and months for it to really mature and get really strong. So what happens is the mix of this immature collagen being laid down, as well as your macrophages eating up all the old dead tissue, so all the old cells, the old extracellular matrix, all the things that help keep the heart together, suddenly you're weakening the heart muscle and you're replacing it with something that's not yet strong, and that predisposes you to rupture. When you get a rupture, there's kind of 3 key areas in which the rupture has a significant effect. The first is if you've had an infarct affecting the papillary muscles. They're the muscles that connect from the ventricular wall to the ventricular side of the valves, the atrioventricular valves. So whether that's the mitral or the tricuspid valve, the papillary muscles connect to them. And if you rupture one of those, what their job is to keep the valve closed during systole. So when you rupture one of these valves, suddenly you've got one of the papillary muscles, suddenly you've got no force trying to keep the valve closed against the pressure inside the ventricle during systole, and you get a valve prolapse. And what that valve prolapse does is it allows blood to shoot from the ventricle back up into the atrium during systole. This valvular regurgitation, depending if it happens on the left or the right side of the heart, can result again in almost instantaneous heart failure. So people, when it happens in the left heart, they can almost immediately start to develop acute pulmonary edema and APO. And so they go from sitting up in bed fine to suddenly being incredibly short of breath. They can't catch their breath, their oxygen saturation drops. If it happens with the right heart, you kind of get this very quick development of heart failure. So they start to very quickly develop the peripheral edema and they get a very large raised JVP. So that's one kind of issue. And of course as well, when you get this valvular regurgitation, it drops your cardiac output, because now instead of directing all your blood through the semilunar valve, wherever it's going, whether it's going to the lungs or to the body, instead of directing your blood that way, it's now getting shot up the low pressure side of the system as well. So your cardiac output drops. If it happens in the ventricular wall and you get a rupture there, suddenly all this blood that's usually in the heart can now start getting pushed out into the pericardial space, which is it's a space that is usually filled with only like a mil or two of fluid, if that, of kind of serous fluid, and that's just to help keep it lubricated. When it's a potential space is what the word I was thinking of. So if your ventricular wall ruptures and you get all this blood pulling out into the pericardial space, that's called a hemopericardium. And your pericardium, the sheath that surrounds the heart, it's fibrous and it's very tough. It doesn't have a lot of stretch in it. So as the blood kind of fills this space, the space can't expand. So instead it starts compressing the heart and pushing the heart to the side so that the blood can keep being pushed out into this pericardial space. Compressing the heart like that, it causes a diastolic failure. So it prevents the heart from filling during diastole, because suddenly now, instead of having this nice heart with lots of room in the ventricles to fill with blood, you're squeezing the heart, squeezing your heart, pushing it further against the side. And that means it can't fill, which means you drop your cardiac output very rapidly. And this can be a rapid cause of death, cardiac tamponade. We actually talk about cardiac tamponade and cardiogenic shock in our physiological shock lecture. So if you want more information on that, have a look in the physiology playlist on the YouTube channel. So this is one of those kind of very emergency conditions and requires urgent intervention. And if you see on TV shows and in movies, the person that kind of jumps on the patient's chest with the needle and stabs them in the chest and kind of draws back and pulls back blood, or they pull back fluid, typically what they're doing is they're trying to relieve a cardiac tamponade, because if you can't fill the heart, your cardiac output will very quickly drop to zero. So that's an emergency, and that's another one of the things that used to kill a lot of people. The third kind of rupture you can get is of the interventricular septum. So the interventricular septum is the wall between the left and the right ventricles. And if you get a rupture in that, then suddenly you get mixing of the blood in the left and right ventricle. And that causes mixing of oxygenated and deoxygenated blood. So as well as lowering your cardiac output, because suddenly the blood can just move from one system to the next, it's like an instantaneous shunt, you start also, the blood that does end up getting to the periphery is typically very low in oxygen. And because of that, people can develop cardiogenic shock. The other thing that can happen as a result of this kind of process of you removing some of the wall, and replacing it with collagen isn't functional tissue, right? So cardiomyocytes, they're functional in that they have the ability to contract. And that contraction is the really important thing in the heart, obviously, because the contractility is what allows it to pump blood. When you replace it with collagen's kind of like a space filler. It doesn't really serve a purpose. It's basically just patching up the hole. And so it's not contractile. And because it's not contractile, what you can have is you can have regions of the wall of the heart that aren't contracting, and so the blood that sits against those parts of the heart stays really still. And remember, the key thing to remember for pathology is that stasis is the basis. So most things that go wrong in the body happen because something is static. And so in this case, when blood becomes static, you get development of thrombus. So you get clots forming. Because blood is supposed to be constantly agitated, constantly moving around. And that's one of the reasons as well people get deep vein thrombosis when they're on planes or when they're in bed for long periods of time. It's because the blood becomes static in the venous system, and then suddenly, because it's not being moved around all the time, it starts to clot. So here, what we mean by mural thrombus is that you get a clot forming on the wall, and that's because that region of the wall isn't contracting, because you've just replaced all the functional cardiomyocytes with immature collagen. So that's about a week post-infarct. Then we start to move on to, and there's a typo here, this says 1 to 8 days. Should be 1 to 8 weeks post-infarct. So 1 to 8 weeks post-infarct, your collagen deposition kind of increases with time. And as I mentioned, over the coming weeks and months, the collagen starts to mature and become proper collagen. So it moves from this kind of weak, immature collagen to nice, really strong, mature collagen, similar to concrete. Because of that, your wall is now strong. And again, you've replaced the functional tissue with a scar, and because of that, you've still got the risk of having a heart failure or arrhythmia. So if you've scarred the His-Purkinje system, for example, you might not immediately have an arrhythmia, but further down the line, and if the heart's put under a lot of stress and where it's relying a lot more on really good conduction, you can still develop an arrhythmia, or over time, as your heart starts to decompensate for having this big bit of scar tissue replacing some of the muscle, the heart can fatigue a little bit and you can develop heart failure from that. The other thing that can happen is that if you've got high pressures occurring in the ventricle during the period of which your collagen is maturing, rather than getting this kind of rupture picture that you see here, the collagen is strong enough to prevent the rupture, but the pressure still causes bits of the wall to start to balloon out before the wall gets back to its full strength. And that ballooning out is called an aneurysm. And of course, so the aneurysm is composed mainly of scar tissue in kind of interspersed with some cardiomyocytes. So it as well has that poor wall contractility, and it's exacerbated that stasis, because what happens is that so if you've got like your wall here, and then it's never this kind of, it's not this exaggerated, but what happens is that blood can then get stuck in here, and then it just kind of pools in this little area to the side, and it never really gets cleared out. So you get this static pool here, so you can get very large thrombi forming in this area. So the poor wall contractility from both the scar and from an aneurysm can both result in a mural thrombus forming. The reason that we worry about mural thrombuses is that if it happens in the right heart, you can end up flicking off pulmonary emboli. And if it happens in the left heart, you can end up flicking off clots, which then form strokes, or they can cause critical limb ischemia. So, they're the complications related to an acute myocardial infarction. I hope that makes a little bit more sense. As I say, we talk about a few of these issues in the physiological shock lecture, which is already up on the MedShoots page. You can find that either by going to our YouTube channel, and it's so just clicking below and clicking on the MedShoots, and that will take you there. It's under the physiology playlist. You can also find it by going to www.medshoots.wordpress.com and clicking on videos. On the MedShoots website as well, there are also a number of podcasts that have been made by the MedShoots team. It's called DrugBytes. It's short pharmacology snippets to help you get through med school. So you can find all those episodes on there as well, and you can also find all the show notes and a number of other resources. So I'd recommend checking that out. If you've got any questions from this tutorial, feel free to put them in the comments or send us a message on Twitter, Facebook, Reddit, or YouTube. You can do all those things just by searching MedShoots, or if you'd like, you can also send us an email, medshoot@gmail.com. If you've got any topics that you'd like us to cover, you can also send us a message via any of those forums. But if you've enjoyed the video, please like and subscribe, and keep an eye out for our next one. Thanks very much for watching, and I hope you found it useful.